All right, everybody. So we're going to start today building on what we talked about, what was it, about a month ago, 5 weeks ago on the ankle. So if you didn't view the ankle webinar, then some of this may be like flying over your head, but because we're going to be looking at the same patients and we're going to be discussing how that change just kind of builds one thing on top of the other, and hopefully it kind of starts bringing these cases together for you. Welcome, Gino. I see you join. And we're already going ahead here with the webinar. So next, we're going to go and just do a quick review of normal gait. And we're going to do what we did last time, but now we're going to be focusing on the knee. All right, so remember, I'm going to go ahead and stop in some subphases, and I would like you guys to type in to what subphase I stop it at. All right, so the right leg facing you, what do you guys think that phase is that this guy is in, as we refer to as Speedo Boy? So what phase do you think this leg is in? I'm looking at the chat box. Come on, guys. Mid stance. Excellent, excellent, excellent. A bunch of mid stances flying in. Very good. Very well done. All right, cool. And how do we know that? That's because it's in single limb support. The other leg has lifted and is coming forward. It's kind of an initial swing, it looks like. So that's a good call. Good job. All right, what about that? Right leg. Initial contact. Excellent, and could be loading response. So not terminal stance, that is loading. We're talking about the right leg, not this leg, the right leg facing us. So it is initial contact and soon to be loading. Now we're going to talk about the ranges in just a second. Looks like you guys have got your subphases down really well. Okay, how about that right there? What's that? I'm watching the chat box. Okay, terminal stance. I had a couple of terminal stances, and it's hard to tell right here. I think, personally looking at this, that he's already contacted on this side. So this would be probably early pre-swing, late terminal stance. I'm not going to sit here and argue about that one. Let me see if I can get a better pre-swing. Does everybody see that would be pre-swing? Because remember, our markers are double limb support. Anytime we're in double limb support, that will be pre-swing on one side and loading response and initial contact on the other side. That's just the way it is. Whether we like it or not, whether it looks like what it's supposed to look like, it's just what it is. Those are our start and stop points. All right, so that was a quick review there. Now let's move on. You guys got your subphases down really good. So remember this sheet at the ankle. So let's review the top range of motion that the knee goes through. So you see that in loading response, we start at neutral, supposed to land on a heel, right? A neutral ankle. And then we go into some plantar flexion. That's flexion up here is plantar flexion. Then we come back to, what am I talking about plantar flexion? I'm talking about the knee here. Geez, sorry folks. So we're going into a little bit of flexion in loading. So we land on a straight knee. We land on that square ankle. We get that heel rocker. We go into 10 degrees, maybe 15 degrees of knee flexion. Then we start straightening the knee out as the body weight progresses over it. And then we come back to extension in late terminal stance. Then in pre-swing, the knee starts flexing. And we'll talk about this piece right here and the muscles that are responsible. And then initial swing, we achieve the maximum amount of knee flexion that we're going to see during the gait cycle. So you can see that this is quite a bit of knee flexion. 60 degrees, half of which occurs in pre-swing. So half of the knee flexion that we're supposed to achieve in the swing cycle occurs in pre-swing, and I want you to remember that because that's going to become very important in our patients. And then the knee starts straightening out, and we go into full extension and we're supposed to land on a straight knee and a neutral ankle. So now let's look at the next line, which is the torque demand. So when we land in loading, we have a little blip that wants to push our knee into extension because we landed on a straight knee, but that doesn't last very long, and then we go into what we refer to as this flexion moment at the knee because we have this ankle rocker, and if this is the ankle, well, let me see here. This is like, I'm all backwards on my videos. Well, this says foot and tibia. So as we land on the ankle at neutral, it rocks us forward. That creates that ankle rocker. Okay, and up here, of course, is the tibia, and then up here is the knee. So as we land, it's throwing us forward. That's referred to as a flexion moment at the knee, and that's that little blip that we see there. It's about 5 Newton. It's not huge, because remember we talked about torque demands during the GaIt cycle. And, okay, I got Gino on webcam. Great. I'm going to move this over so I can see you. Hey, guys. All right, so talking about back to this here. So this little flexion moment exists, which wants to push the knee into flexion, which is then, if you look down here, counteracted by the quads, right? So these are the muscles down below that are active in each one of these subphases. And you can see that we have primarily quadriceps that are on in loading response, and we'll talk about the hamstrings down here a little bit later. So then, as we move into the extension at the knee and the body weight is now progressing over the foot, the muscles turn off. Why do you think that is? Why can these turn off? Why do the quads turn off in mid-stance and there's nothing on in terminal stance? Why do you guys think that? Somebody type that in. Why do you think that there's no quadriceps activity in here at all? Any ideas? I'm waiting. It's not a trick question, folks. So if we landed on this foot and our center of gravity is coming in the back, it's going to be pushing us forward into knee flexion, right? This is the knee up here. But if now our body weight and our body has progressed in front of the tibia, our center of gravity falls in front of the knee, and it's pushing it into extension. So there's actually an extension moment. You see that right there? There's an extension moment at the knee if we have appropriate range, and if our center of gravity is falling anterior to the knee, it's shoving it into extension. So we don't really need a whole lot of quad strength in stance if our center of gravity is anterior to the knee. If. Now remember, how I said, stance belongs to the ankle. So when we don't get that center of gravity in front of the knee, like in the patients that have excessive plantar flexion and can't get their body weight in front of, this is the foot, and they're in too much plantar flexion. The foot's flat to the ground. Too much plantar flexion would look like a tibia back here, which means that the center of gravity, because there's a body attached up here, that means the center of gravity is going to be back here somewhere, and it's going to be pushing that knee into flexion. So alignment is what creates quiet muscle activity during stance. If we don't have appropriate alignment, we don't have the center of gravity falling anterior to the knee joint, we don't have the extension moment in the backward direction to keep our knee straight, and now you're going to need quad strength. So sometimes, because our patients have inadequate range of motion at the ankle, it may have increased demand on the knee and the quad because of biomechanical issues. All right, so then we have a little blip of the short head of the biceps in here, and you're thinking, well, I wonder why that is. Well, this was kind of like a surprise when they did the dynamic EMG studies, and the consensus is the reason this occurs is it's helping to protect kind of the posterior aspect of the knee joint, because, you know, the short head of the biceps only crosses the knee. So that little contraction right there is helping when that big extension moment is occurring at the knee, pushing us into extension. and that contraction of that muscle helps. Okay, so we had that little extension moment there, and then look what happens in pre-swing. This is when we start getting all of that range, right? Half of that range that we're supposed to see. What muscles are active? Do you see hamstrings active here? Does anybody see any of the hamstrings on? Right? So is that a news flash, or does that surprise anybody? Because a lot of people think that the hamstrings are what does knee flexion, and they don't. And that's because the hamstrings are primarily hip extensors because of the lever arm that they have across the joint as compared to the lever arm they have across the knee. So when you think hamstrings, I want you to think hip extensors. The hamstrings are two joint muscles, and yes, they do cross the knee, but they're 2 to 3 times as effective at the hip, and that's how we use them during GaIt with normal alignment. The knee flexors are the gracilis, that skinny, winny little muscle that we all learned about and that we just forgot about somewhere along the way after we took our anatomy test. Because that crosses, what does that do? It crosses the knee. And it actually comes up and kind of does a little bit of crossing the hip. So does the sartorius, right? Sartorius flexes the knee, flexes the hip, so it makes sense, right? Those two would be the ones firing. Primary hip flexors, and then the rectus femoris comes in a little bit later because it's a hip flexor and also will start extending the knee. So I want you to take a good look at that. And then again, the short head of the biceps is what comes in. So it's the single joint muscles, and the only 2 joint muscles that contribute to hip flexion and knee flexion are the gracilis and the sartorius. And those are your knee flexors, and you're thinking, those are like the scrawniest little muscles. I can't believe that they're responsible for this. And you're right. But the point is that this right here, the majority of what occurs here in pre-swing occurs passively. And you only need a little bit of help with those skinny muscles to get the rest of the knee flexion to occur. So knee flexion during swing is not a power event. It doesn't take a whole lot of strength to be able to do that. What it takes is momentum, and we'll talk about that when we look at the video on the CVA patient. So keep in mind that a big problem with not enough knee flexion frequently is not enough momentum, and not enough momentum is a problem when people don't have adequate step length. Okay? So let's move on then. That's kind of your muscle activity, and you should kind of look at this and don't just like put it aside, not look back at this. Kind of study this, because this kind of stuff should be inherent for us as PTs so that we understand the GaIt cycle really well. Because as I said before, we own this and we need to really know it well. And if you don't know these sheets and you don't know the ranges, you don't know where the greatest torque demands and the moments are during those subphases, and then you don't know the muscles, then you don't know GaIt. You guys have got the subphases down really well, so I'm real happy to see that. Okay, so we're going to move on now, and we're going to take a look at just a quick thing. Remember, our best markers for GaIt analysis are those periods of double limb support. This is just review from the last one. Initial contact is when the foot actually hits the floor. It may not be the heel, it may be the forefoot, maybe the lateral border, but that's what initial contact is, or when weight transitions over onto that side. Initial swing, we demarcate that with when the femur actually begins advancing forward. And the reason I use these definitions is because, again, as I said before, patients don't look anything like normal. And then terminal swing is when we achieve the maximum step length before the foot hits the ground. Because again, some of our patients achieve a big step length, when you're going to see that in our CVA lady, and then she brings it back. So let's take a look at her. Let me just zip it forward here. And there she is. Okay. So we're going to be zooming in on her lower leg here. All right, so now I'm going to do the same kind of thing. Now again, we're looking at the knee. Forget the ankle. We already talked about this last time. You can't really totally forget the ankle because what's happening if the ankle affects the knee. But I want you to, we're going to be analyzing the knee right now. Okay, so what subphase, folks? Type it in. Okay, AJ says mid-stance. Now remember, period of double limb support. So can that be mid-stance? I know it looks like what mid-stance is supposed to look like. Next guess. If we're in double limb support, what is this? It could be initial contact, good Tracy, and it could also be loading, right? Because the other foot, of course, doesn't look like pre-swing at all. Let me advance her 1 or 2 frames. Okay, so initial contact was probably, oh, so there is her loading response. Now, it didn't change really a whole lot, did it? I advanced that about 5 or 6 frames. And her position of her knee, we're talking about her knee now, her knee was supposed to do what? From initial contact, which was a straight knee, that was okay, into loading, it's supposed to do what in loading? What was the knee supposed to do in loading? It's supposed to flex, right. Did it flex? Did her knee flex? Not at all, right? So let's just watch it go through. Watch what happens in loading here. She loads. Okay, now there, oh, what did that do? What do we call that? Boom, backwards. Watch again. Oh, that one was straight. Then she lands on here. This every step's, oh, wobble, wobble, and then boom. What do you call that movement there that we just saw? That movement when it's wobbling, we call that a wobbles, and then she smacks it back. What do we refer to that as? Anybody know? Okay, hyperextension is a position of extension past neutral. She's actually at neutral. So, okay, Janu Ray Cravatum, that would be the Latin for hyperextension. Good. So I'm not going to get hung up on that, but what I want you guys to understand is we refer to that movement as an extension thrust. Now, an extension thrust doesn't always equal hyperextension because I think you would all agree that she's not hyperextended. She's at neutral, right? This knee is at neutral. Does everybody agree with that? But if she continues to thrust and continues to walk and continues to smack that knee back over time, that knee will begin hyperextending. So when you refer to this kind of deviation that you see in stance, okay, so in loading, she loads straight, and then she thrusts into extension at the end of loading, and in mid-stance, she's actually straight, because it's supposed to be straight, right? And it's supposed to be straight in terminal stance. But her big problem is right here in loading. Sometimes she lands and thrusts it. Sometimes she lands in flexion, and then we're going to go back a little bit, and then that one that was straight, there's one step in here where she lands in some flexion, and then she wobbles back and forth, and then thrusts it. So every one of her steps is not the same. But what we see, what the most obvious gait deviation is on this woman when she walks is this smacking of the knee back, right? But remember, we analyzed her at the ankle as well already. And what did we determine was her problem during stance at the ankle? Does anybody remember what this woman's main problem in stance was at the ankle? You guys remember? Hey. Yeah, she didn't have enough dorsiflexion. Good job. This woman was in what we refer to as excessive plantar flexion during stance, not because she's actually in plantar flexion, but because we're supposed to have 10 degrees of dorsiflexion, and she never gets there. And because she never gets there, let me take it back just a little bit. Come on, let's go. So because she never got there, so that's why you can't ignore the ankle in stance. But the obvious gait deviation that everybody notices is this knee going boom, 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 smacking back, boom, 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 smacking back. And that's actually because of what's happening at the ankle. All right? So even though her loading response deviations at the knee are extension thrust, wobbles, sometimes she loads in flexion and then smashes it back. Sometimes she loads in extension and stays back. So the primary cause of that, though, is what was happening at the ankle. So now let's talk about swing. So here she is in swing. Let's watch swing. That's pre-swing, right? Does everybody agree with me that that's pre-swing? Why did I say that's pre-swing? What do you guys think? Okay, Tracy agrees. Okay, heel rise. Okay, AJ says heel rise. What if somebody's back on their foot and there is no heel rise? That's not our marker. Remember, our marker for pre-swing is full stand on the left or double limb support. So good, good. That right there, even though her heel's coming up, you're right. She's supposed to be in a lot of toe hyperextension. She's supposed to be in plantar flexion here, and she's supposed to have, anybody know how much knee flexion we're supposed to see here? How much knee flexion are we supposed to have in pre-swing? What do you guys think? $20-ish, good. 20, 30-ish, half of what we're supposed to see. So just remember that. Pre-swing's half of the 60, so it's almost 30 degrees. That's a lot of knee flexion. She's nowhere near that, right? So she's already going to be playing catch-up in initial swing. So let's watch initial swing. Watch the femur. Okay, slide past it. Let me try again. All right, so her initial swing was done and over before I could even stop it. So let me try pre-swing. So technically, that can qualify as pre-swing, even though she's still on the heel because she landed on the other side. So technically, that's pre-swing. And I'm going to watch for that femur to come forward, and I'm going to call that initial swing. There. So what I stopped it at before was actually initial swing on her, and those 6 or 7 frames before was pre-swing where the knee is totally straight. And then initial swing, she is, what, is that 60 degrees of knee flexion? Nowhere near it, right? Now I'm going to let it run, and I want you to tell me how much knee flexion, what's the maximum amount of knee flexion you think this woman achieves just through the whole swing cycle? What's the max amount that you're seeing out of that knee there during swing? What do you guys think? 30? Everybody in agreement? About 30 degrees total? Yeah. That's half of what she's supposed to get. Now, we'll watch it again. So, swing only, watch. She's way late in pre-swing. None of it happens passively because that was pre-swing there, totally straight. Then she goes to initial swing and then mid-swing. Never really gets it out there, never gets the full flexion. And remember, we said that if you don't have adequate knee flexion, you're going to have swing limb advancement problems. Well, let's see. Does she? You guys can't really see it well here, but from the posterior aspect, you do see, when we see that posterior view, let's look at that posterior view here. So watch this. She scuffs, right? Now we determined when we looked at her ankle that she had excessive plantar flexion, correct? But remember, she has a drag. You can see that drag occur right there. She kind of pulls it through, and her foot's kind of down, and she's landing a little bit on the lateral border. But let's not be misled to believe that the reason this foot is dragging is because the ankle is in plantar flexion. The reason this foot is dragging is because of what we saw here. That knee is not bending. Now, we're not talking about the hip yet, but watch what she does. That hip comes up to quite a bit of hip flexion, right? And that's her saving grace, because the hip is compensating, and she actually overcompensates. And we'll talk about that when we get to the hip. That's referred to as a pass retract. She brings it way up and then drops it back. So we've got a big swing limb advancement problem, and the primary deviation for this woman is at the knee. And yes, she has excessive plantar flexion, but that's not the primary reason she's got swing limb advancement problem. So again, I want you to appreciate that. And her biggest problem is that she didn't get the pre-swing knee flexion that we needed to see. So that's pre-swing, right? We said you're supposed to get half of it. And remember, I mentioned that that was passive. There wasn't a lot of muscle activity creating that pre-swing knee flexion. So what is the problem? Why do you think she is not getting that knee flexion in pre-swing that's supposed to occur passively? What's happening here? Short stride length on the left. Excellent. And why do you think, we talked about this, why does she have a short stride length here? She has a short stride length on the left, but why? Just because she wants to? Or is there something else going on here? Ankle. We determined that this ankle was an excessive plantar flexion, or she didn't have enough dorsiflexion during terminal stance. That contributed to limited step length, which then is causing a problem with the passive knee flexion on the ipsilateral side. So you can see now that by correcting a stance problem can have secondary benefits to improving swing limb advancement and lack of knee flexion problems. So if we get adequate step length over here, we would take care of a momentum problem here. Now some of you may be saying, well, she's a CVA, she probably has extensor tone. Yeah, she might, you're right. But if we don't get the long step length and we don't create the momentum, she has nowhere to collapse into passively in order to get half of that knee flexion. So again, I point this out because that is why it's so important for you to start with stance, fix the stance problems, then deal with the swing problems. Don't start fixing the swing problems and ignore the fact that somebody doesn't have adequate dorsiflexion during stance, because it creates a lot of problems further up the chain. All right, so that's the take-home message with her. Okay, let's move to the next one. We talked about functional significance of those gait deviations and blah, blah, blah. I talked about all that. All right, we talked about the most likely cause of her swing deviation. So now we're going to go to this guy. And this was the spinal cord injury patient. Now, if you guys remember him from when we analyzed the ankle, do you guys remember what we determined as the primary deviation? Hold on one second, folks. I have to. For those of you that just came on, I can't make anybody a presenter but me. So you need to just put in the audio pin or do whatever you need to do to get on. All right, so does anybody remember what we determined as this guy's primary deviation at the ankle during stance? Okay, I'm waiting for some responses in the chat box. Nikki, you guys, I just keep getting AJ and Gino's group responding. Come on, you guys, some other people can type in. Tracy's been typing in too. So what was this guy's primary deviation during stance? Okay, increased or excessive dorsiflexion. Very good. Good job, Tracy and crowd. So yeah, he was in too much dorsiflexion in mid-stance and terminal stance, which then leads to the obvious gait deviation that everybody would see, is that this guy doesn't straighten his knee out during stance. And so he walks kind of in a flexed knee gait. But again, just because the knee deviation is the obvious one, excessive knee flexion, we determined last week that the cause of that was because this guy is collapsing into excessive dorsiflexion in mid and terminal stance too much. And we determined that was, he's a L3 complete spinal cord injury, was because he doesn't have good plantar flexors. They're extremely weak to absent. So again, I just point this out because the excessive knee flexion that we see, even though that's the more obvious deviation, this guy, does he have limited knee flexion during swing? No, he's pretty close to normal, right, guys? He's getting close to 50 right there, right? So yeah, he may not be quite 60, but hi guys, but not looking so bad here in swing, right? He's looking pretty good. So this guy's main problem was an ankle and a stance problem. He doesn't really have a swing limb advancement problem. So we're going to move on from him to the next patient. Okay. Good responses, good group. You guys are knocking this one out of the ballpark. All right, so again, I want to reiterate, the most obvious deviation and the first one that you see frequently at the knee, that's not always the primary. All right, so now we're going to take a look at a couple of other ones, and there's going to be like stump the chump kind of questions in here, okay? So we're going to take a look at someone with muscular dystrophy, and we're just going to watch her walk. And this is not a professional video. This is just one that I did, okay? So I apologize for the thing moving all around, but, you know, hey, what do you do in the clinic when you see something wild and interesting? So watch this gait, and then we're going to take it one thing at a time, okay? This is the part I have to apologize for. Sorry for making you guys sick. Here she comes around the turn. So we're going to take a look, and we're going to analyze that left leg, okay? So we're going to watch her walk. Let's look at that left leg. Both of them are doing the same thing, but the left one's worse, okay? So just look at the left leg. All right, so I told you her diagnosis. She has muscular dystrophy. So now I want you guys, I'm not going to stop it, I want you to tell me what you're seeing at the ankle and the knee in loading response for this woman. Tell me what is happening in loading response. I know there's a lot of other bizarre things going on, but I only want to know about loading response. No heel strike, and she goes into Janu Raker bottom. Good job. That was from Christian. Right. She's smacking that. She actually has low heel contact, but it's certainly not normal. It's not that nice heel rocker that we would want to see, and then that foot and that tibia coming forward, right? This woman lands, she slaps that foot straight, and then the tibia goes snapping back. And she is in hyperextension. And so she's loading actually an excessive plantar flexion. So if you guys are going to call me on the phone and you're going to say, Andrea, I've got this patient with muscular dystrophy, and you were going to describe her to me on the phone, these are the kind of words and the kind of language I would like to hear. Is in loading response, she's loading an excessive plantar flexion. She actually has a little bit of a slap. You can't hear that, but you would if you saw her in person. And she doesn't go into any knee flexion. Does everybody appreciate the fact that this woman in loading is supposed to go into some knee flexion, right? We determined that when we looked at normal gait. Does she ever go into knee flexion? No. So let's hypothesize at this point. You don't have an opportunity to go test her, but what would you want to check on her? What would you want to drill to right away? Okay, you saw her walk. You have 15 minutes. You can't do a whole eval. What are you going to want to look at on her? She's muscular dystrophy. Okay, somebody just typed a very long answer. Adequate dorsiflexion passively at terminal stance. Okay, so no power toe off. So what are you going to want to evaluate? What are you guys going to want to know about her? Okay, so Christian's going way up the chain. So we do know that muscular dystrophy has proximal weakness. So dorsiflexion strength. So you're over there at Hilltop, you guys think she is dorsiflexion strength. Okay, so go back to your torque sheet real quick and take a look at your torque sheet and tell me what muscle is the most active. If you have the ankle one too, you can put that one next to it. Tell me what muscles are active in loading response. You guys are just throwing all sorts of muscles out there. So gracilis and sartorius are our flexors. Look at loading response, go down the sheet. Tell me what muscle. Quads. Very good, AJ. It's the quads. Why is it the quads? Because that's primarily the muscle that's taking up that flexion moment. Remember when we land on this ankle, and pretibials, yes, pretibials also need to be strong. Somebody said dorsiflexors earlier. So we have to have adequate pretibial strength to not let that foot slap down. And she's going, poof, she's slapping it down. But what is happening in loading is the knee is getting pulled forward and that tibia is getting pulled forward into that flexion moment, and you see the quads are firing. So I'm going to tell you guys that when I see a gait pattern like this, when somebody loads and never goes into knee flexion, the first place I look is quad strength. Now, I may be surprised. There could be some other reasons for that gait pattern. What might be another reason somebody smacks and keeps the knee in extension during loading? So we're going to check her quad strength, and I'll tell you what it is in a second. So what else? What else might cause somebody to walk like that, to smack that knee in extension and never let it bend? I'm waiting, folks. Okay, a contracture of the plantar flexors. She could have a plantar flexion contracture, and she just smacks it down and never can get over it. You see that with a lot of our patients. That's one thing. Hamstrings are active when they shouldn't be. Hamstrings are active when they shouldn't be. No, I don't, and we can't talk right now, but if we were in person, I would make you kind of elaborate on that. But that one probably is not, but good. I appreciate you going out on a limb on that. Hamstrings would cause, you're thinking that they're causing her to go into extension at the hip. That's probably what you're thinking. But that would also cause flexion at the knee, so probably not. What else? Sensation-wise, what kind of lack of sense would cause somebody to smash their knee into extension and not want to go into flexion? Yeah, she doesn't have good proprioception. So let's say she doesn't have any proprioception. Those would be the things that you would worry about and be concerned. Now, because she's muscular dystrophy, you guys may or may not know this, but do muscular dystrophy patients have sensory deficits? Do you guys know the answer to that? No, they don't. They have muscular dystrophy. They don't have cord problems. They don't have sensory problems. What other patient population that we had a huge epidemic of back in the 40s, and now we see the secondary ramifications of that in our clinical practice, have very similar clinical presentations? Polio. Very good. So she walks very similar to a polio patient that has exclusively weak quads or absent quads. Now, I went and tested her because I happen to know that muscular dystrophy doesn't have sensory deficits, so I didn't even worry about that. But if it was a different diagnosis, I would worry about that. And I checked her dorsiflexion range, which was normal. So she didn't have plantar flexion contracture. But what she had was 0, and I am saying 0 quads. And look at how well she walks. I mean, that woman's moving, right? I mean, for somebody with no quads, that's pretty impressive. But that's what somebody can do when they have normal sensation and they have weakness or absent motors. They know where that leg needs to be. And that's why those polios did so well. And that's why muscular dystrophies surprise you when you put them on the mat and you do manual muscle testing. You're like, holy moly, I can't believe it. She also has like 2 minus hip extensors. So, and all the glutes, all of the proximal muscles in muscular dystrophy tend to be weaker. And then as you go down the chain, they get stronger. So it only makes sense that this woman would smack that leg into extension and keep it there, and she doesn't ever want to get that center of gravity that we talked about at the very beginning of the lecture. She doesn't want that center of gravity falling at any point in time behind the tibia, because then that'll push it forward, which then causes the knee to flex, and she doesn't have quads to stop it. So what does she do? She keeps it in front of it all the time, which shoves it into extension, and biomechanically she's solved the problem. And she can do that because she has normal sensation. When your patients with brain injuries, spinal cord injuries, and CVAs don't have normal sensation, they don't do this that well with the weakness that they have. And sometimes they actually are stronger than a patient like her, but they don't walk anywhere near as well. And that's why. So that afferent input, that input from the sensory system, is so important to be able to time what needs to occur during the gait cycle. And she can do it. Now, I'm going to pick your brains a little bit more. Let's say she comes to me, and she comes to me because she has posterior knee joint pain. Okay? Her left knee is starting to hurt her, which over time you could see is going to happen. If it's not happening now, it's going to happen if she keeps walking a lot, right? She's just smacking that thing, and she's actually going into hyperextension range. So just like the post-polios, this woman is going to develop joint structure destruction and pain. So what might I do from an orthotic standpoint, or do I even have an orthotic option for her to help with that knee pain? Okay, so Christian says I could put her slightly into dorsiflexion. So I want you to think about that. I appreciate you contributing. Floor reaction AFO. Okay, so when we say floor reaction AFO, we talking about like a PLSO or something? Is that what you mean by that, Tracy? It'll change the mechanics at the knee. So Christian feels that if he puts her into dorsiflexion, and I'm not picking on you, this is good discussion. So you're saying if I put that tibia into dorsiflexion, the foot's on the ground, and I put that tibia into dorsiflexion, that's going to take away from that stress on the knee. Now that is correct from a biomechanical standpoint, but can this woman tolerate that tibia being in a forward position and having her weight behind it? She has no quadriceps, so keep that in mind. So biomechanically, your answer is correct, but given her diagnoses, you can't do that to her. You have to let her tibia stay back here. You can't take that away from her. I'm thinking she might demonstrate less rake or bottom. Okay, so those are all good thoughts. Let me see, I missed this one. Tracy Ryan, she would buckle, yes. Yes, she would buckle, Tracy. Very good. So there was a lot of coming in here. A knee extension block. Good job, AJ. So what's a knee extension block? Let's talk about that. So Christian wants to put her forward because that'll keep that tibia from going back into that painful place. But the only point is she can't go there because she doesn't have a quad to stop her. And you can't put her in a locked AFO in this position because you need great quads to do that. So remember, when we put people in locked AFOs, we've increased the torque demand at the quads. So now she's posed us a problem. She's got posterior knee joint pain. So AJ's right. We're going to put her in a brace that has an extension block but allows her still to plantar flexion when she loads. And that usually is beyond the scope of this lecture. But what I want you guys to think about is this is somebody that poses a challenge for you because you can't just put her in the generic AFO that's going to create this because she can't handle it. She doesn't have any quads to handle it. So we need to let her land this way, and we need to protect that knee joint with something across the knee, usually a KAFO, that's going to not be locked at the ankle, that allows it to be in plantar flexion and allows this to be in some hyperextension, but shy of the painful hyperextension range, but still allowing some hyperextension. And the reason I bring that up is we're going to see, and you may have already seen people like this with a lot of hyperextension. And just because it looks ugly and just because it's painful, you can't always take all of it away because there's a reason they went there. So you have to understand what you're doing with your orthotics and your mechanics of those orthotics before you just go locking people up and thrusting them forward, because they're gonna hate the brace because now all of a sudden you're taking away their ability to walk. Okay? So that's just some food for thought there. That's a tricky one. But you guys were you were right on it as far as your thought processes. And Gino's group said KFO with posterior stop and extension spring. That's pretty much it. That's the correct answer. Okay. And Christian always said KFO, knee orthosis. Now, I am going to say that when you have huge moments at the knee into extension, a lot of hyperextension, the Swedish knee cage thing doesn't work. Okay, there's not enough above and below the joint to actually stop that moment. So some doctors will say, put a Swedish knee cage or just a knee immobilizer on them. It's not enough lever arm to control that thrust. So that's why you usually have to go to a KAFO, but you'll let the ankle be free. You won't block the ankle at all. And that'll give you enough leverage to stop that extension at the knee. All right, so now I'm going to show you a completely different situation. Again, kind of picking your brains. Now, this patient is a CVA patient. Then we'll wrap it up with this one. All right, so I want you to watch your walk, and we're talking about the knee, but we can't ignore the ankle, correct? This is about the knee, but this woman, what do you guys think about the knee flexion that she demonstrates? Tell me about her knee flexion during, what knee flexion? Very good. Yeah, pretty much what knee flexion. Now watch her walk. She doesn't have any, right? Now, remember we talked about, she also has what going on here at the ankle? What's going on? Yeah, she doesn't have any dorsiflexion. This woman is actually plantar flexed, right? And externally rotated. And she's got pretty classic CVA gait. We refer to this as stiff-legged gait. But remember, we have to start here in stance. We're going to want to, remember I told you want to increase the dorsiflexion so she can get her body weight in front. And maybe we'll get a longer step length on the other side. And then maybe we can increase some of the passive knee flexion and pre-swing. Now she's a CVA, so I'm also going to be suspecting what's going on at the knee that might be contributing to this lack of knee flexion. What other than what I just said, increasing her dorsiflexion so she can get a longer step length? What else might be happening? Extension tone. Good, AJ. Okay? And that's very good. Tone, sensory. Very good, you guys. Good job. So I'm going to have to look at that. But I'm going to fix this first because I know this is a problem. So my immediate way to fix this is to do what? I want to fix it within one session. I'm not going to do bow bath. I'm not going to burn incense. I'm not going to do smoke signals or anything. What am I going to do right away from an orthotic standpoint? What could I do to that foot? Okay, if I dress the toe out, that is actually a hip problem. And we'll talk about that when we get to the hip. AFO. AFO. Very good. So I'm going to put her in AFO. I'm going to get it into the maximum amount of dorsiflexion that she can tolerate. She does have a plantar flexion contracture, so I can't go shoving her into dorsiflexion that she doesn't have. So I'm going to put it in the maximum amount of dorsiflexion, which is just shy and neutral. That's all she can handle. And then I'm going to cheat. If that's all she can get to, right there, I'm going to cheat by putting something under the heel and tipping that tibia forward. That's the heel lift trick, remember? So it's going to be a open dorsiflexion AFO. It can go as forward as, it won't let her go further back past neutral, but that's still not enough for the step length I need, so I'm going to tip the system by putting something underneath the heel. So I did that. Okay, so now let's watch. I did that, and I did some gait training with her. Oops, wrong person, sorry. Now let's watch what happens. Okay, so that's the same session. The next day or something. So what do you think? Is the knee flexion better? Okay, Christian doesn't think it's better at all. You don't think she's getting any more knee flexion? Okay, wait. She doesn't get to go over there yet. Come on, Christian. She's got a little bit more knee flexion. Now, granted, it's not normal, and I don't like it either, but it is better than what you saw before. There wasn't bending at all. So, I don't want to spoiler alert. I'm not going to let her go over there yet. So this is a stroke patient who then, I looked at her extensor tone. Yeah, she had some. She was on some baclofen, and we were trying a bunch of different things, trying to get more knee flexion. we were working on trying to tip her forward. We were working on treadmill gait and just adequate repetitions, and I'm trying to get her to bend more and more. Still not pleased with what I'm seeing over there. So then watch this. So what do you think now? That's what I did, AJ. That's exactly what I did. And then I told her that she was so busted. How is it that that woman who has been walking with that stiff-legged gait, and I'm doing all the tricks I have in my book, and I put her on this compliant surface, and she pretty much is achieving almost normal knee flexion. So what do you guys think? Other than wanting to strangle her, what do you think? Perhaps a large sensory component? Maybe. Somebody else want to chime in? What do you guys think? This is the beauty of a foam pushing her into dorsiflexion, maybe. Maybe. This is a perfect example of what happens when people are allowed to develop with central nervous system disorders, are allowed to develop compensatory movement patterns, which we refer to as learned non-use. So this woman learns to walk on linoleum because our job as therapists is to get her as independent as possible, as quickly as possible, right? So then we're like, oh, she's walking with a single point cane, and we're all really excited, and we let her do that. All of us along the continuum, from acute hospital therapists to not. And she loads a motor program as her brain is reorganizing after the stroke that is the linoleum walking motor program. That's the preferred motor plan that she is using now because that has become the automated motor plan. This is motor control in action as you watch it. She totally has the capability to walk normally, yet she has chosen the more simple, more automated motor plan, which she was probably trained to do from the first minute she had her stroke to the acute rehab, to the subacute rehab, to the outpatient. And now that's the preferred plan. Yes, her gait velocity is a lot slower. She has a little more support in the bars. She's more confident. But this woman now, I can brace her and baclofen her and do whatever I want. But what she just told me here is what my treatment plan is going to be with her. And so what do you think my treatment plan is going to be with a woman like this, as opposed to just putting the AFO on her and having her walk and do that? What do you guys think I might do? So I've been talking, and I haven't been reading you guys' chats. Altering velocity on the linoleum, you could do that. You could rewrite the linoleum walking program. We've got to get her to bend more, and barking at her during a therapy session isn't going to do it. So walk on foam, on level surfaces, good. We want to create an variable speed gait, good. We want to create environmental challenges that will create that motor pattern so that she can have more repetitions of that you're seeing right there. And it may be different surfaces, it may be different speeds, it may be different assistive devices. But that's where your creativity comes in as a therapist. Long walks on the beach, excellent. That is exactly what we're talking about. And with our central nervous system disorders, let's not pigeonhole ourselves. This is classic neuroplasticity in action. And we as therapists across the continuum contributed to that woman's learned non-use pattern over linoleum. And then now you get her and you have to undo that. And that becomes a little more complicated. Okay? Undo that. And that comes with repetitions and creating environmental constraints and situations that will promote the motor pattern and the movement you want. So I'm going to close with that thought because we're getting to the 10 o'clock hour and I got another call coming on. But hopefully you guys found that helpful and thought-provoking. And I did record this and I will be posting it on YouTube.